Welcome. We're recording this meeting for to send out to people who aren't able to make it tonight, but I'm glad you all are able to be here. We have a really exciting presentation for you today based on one of the papers that was recently published in our journal. The presenters today are from Yale University, and they work with the HAVEN Free Clinic. We have Juan Rodriguez-Guzman and Marco Ramos, who are both residents in psychiatry at Yale and who were working as students at HAVEN Free Clinic prior to that, and Michelle Silva, who's the PsyD and an assistant professor of psychiatry, who has been helping out with this project for a long time. I have asked the presenters to talk and give an overview of what they did for like 20 minutes or so, and then afterwards we're going to have a question and answer session. I will repeat this information, but you can feel free during the talk, if a question comes up, if you go down to the bottom of your screen, there's a little button that looks like a talk bubble. It is a chat button, and it will open up a chat box to the right side of your screen. At the bottom there, you can select who you're sending it to. Send it to me, Amber Dunbar, at any time during the talk if you have a question that you want me to ask them later on. But I will repeat that, and you can ask questions at the end as well. So without further ado, I'm really excited to hear what we have to share with you today about mental health in student-run free clinics. So you guys can take it away.
All righty, thank you, Amber. So my name is Juan Rodriguez. I'm a second-year psychiatry resident at Yale. As Amber mentioned, I used to be a medical student at Yale, and during my time at Yale, I was one of the lay counselors and later on one of the folks running the behavioral health program at the HAVEN Free Clinic.
I'm Marco Ramos. I'm a first-year psychiatry resident, and as a medical student, I was involved in the creation of this program.
And I'm Michelle Silva. I'm a clinical psychologist and faculty member here in the Department of Psychiatry and have been involved with the supervision of the program.
Okay, so I thought I would just start out by first acknowledging, just the community of patients and families that have kind of participated and been involved in this program, as well as everyone you can see on this slide. I think for time's sake, I won't go through all of them, but it wouldn't have been possible without all those groups. So the goals and objectives for today are we're going to talk about psychoeducation and its role in mental health promotion and prevention of mental illness. We're going to talk about how a supervised health professional student can serve as a facilitator of a psychoeducation intervention. And we're also going to understand some of the challenges and strategies for delivering behavioral health interventions within a student-run primary care clinic. So first, just to talk a little bit about this, the program was situated in the student-run free clinic called HAVEN. And HAVEN is a clinic where health professional students at Yale can volunteer. It's open on Saturdays, and the population that it serves specifically is adults who don't have insurance and live in the Fairhaven neighborhood. And just to give you some sense of volume, we had about 1,500 visits in 2017 and served about 640 patients. So the vision for the clinic is that every uninsured adult living in Fairhaven will have access to comprehensive quality health care. And it's also the educational goal is that students develop a lifelong commitment to valuing social context and community needs. And I think for both, I can speak for both Juan and me, that our experience working at HAVEN in particular and in this program has really led us to go into psychiatry, I think, as a career. So in terms of the patient demographics, to give you a sense of the population in Fairhaven, it's overwhelmingly Spanish-speaking Latino immigrants who don't have insurance. And as a result, they're generally immigrants who are undocumented. So about 61%, and actually these numbers were higher when we started the clinic, but currently, or started the program, I'm sorry. But currently, about 60% of the patients are Hispanic, 60% of patients at the clinic, their primary language is Spanish, and you can also see some other numbers related to income and average medical debt for patients. So one thing I learned working at the clinic very quickly, I had originally become involved in the clinic just as sort of on the medical side of things, as working on medical teams. And I had a patient who was depressed. I did a PHQ-9 screening tool that I'll talk about, that we'll talk about in this presentation, and they were depressed. And so I walked over to the referrals department, and I figured, just like for patients who have kidney issues, we will be able to, and we referred them to a nephrologist. This particular patient had, issues with depression, and so I thought, we can, refer them to a psychologist. But I found very quickly that that was a sort of naive belief that there would be practitioners who spoke Spanish and would actually see immigrants without insurance. And this is sort of the reality that we face right now, is that there's 11 million undocumented immigrants in the U.S., and that if you look at, this population who suffers from major depressive episodes, many of them don't have access to treatment. And so you can see some of the numbers. This is sort of divided into two sections. The first is around ethnicity, and you can see that Hispanic patients tend to access or receive treatment far less than especially white patients, but also black patients actually. And then you can also see that uninsured patients tend to receive treatment less. And so the population of Fairhaven sort of occupies both of these most vulnerable categories, both being Hispanic and being uninsured. So the way the behavioral health program started is that originally, as I was saying, I thought, we should be able to refer out, patients who were suffering psychologically and emotionally to providers, but there weren't really that many providers who could see these patients in the community. And we also found that there was a tremendous need for services for depression. But we did a sort of screening pilot program and found that between 20 and 30% of our patients suffered from mild to moderate depression and would benefit from mental health services. So we funded this through this program that we're about to describe through the American Psychiatric Association Helping Hands grant, which I'm happy to talk more about. It's a really great grant. It can give up to $5,000. And I won't get into too much detail now, but if people are interested, I can talk more about the grant funding we got. And so originally we were thinking of the program being centered around antidepressants, but we ran into some roadblocks with that on the sort of liability side of things. And so looking at this slide, this is a page from the WHO Mental Health Gap Action Program. And what we found is that we weren't able to just prescribe antidepressants for reasons, again, we can talk about in the question and answer if you'd like. But instead, we decided to focus on sort of the top 3 first-line interventions for depression as listed in the WHO Mental Health Gap Action Program. And those 3 are providing psychoeducation, reducing psychosocial stressors, and then what we call behavioral activation, or promoting functioning and daily activities in community life. And this slide shows, I think, one of the big problems with mental health care kind of systemically in our country is that a lot of resources tend to go at the top of this pyramid, which are sort of specialist services and hospitalization. And so when you think about this, you can think of like drugs, for example, being prescribed by a psychiatrist, or formal psychotherapy delivered by a psychologist. And that's kind of what we think about when we talk about mental health. But it's actually only a small portion of patients that require those services. And those services are extremely costly, but as a system, we tend to devote all our resources there. But the patients that we were actually seeing at Fairhaven were more at the bottom of this pyramid. So they weren't quite sick enough to be hospitalized, for example. And if you think about a more effective mental health care system, it would be one that actually intervened in this sort of preventative way with patients before they got really sick and needed to be hospitalized, and would focus on things like informal community care, self-care, and mental health services in places like the Haven Free Clinic before they actually needed to be seen in the hospital. And so what we decided to do was to use what we call a lay counselor model to deliver those 3 interventions I mentioned, specifically psychoeducation, reducing psychosocial stressors, and behavioral activation. And the lay counselor model basically addresses the lack of human resources that we have the lack of specialists to treat this community, right? And because we have a lack of specialists to treat this community, we just simply don't have enough psychiatrists and psychologists. What we can do is train lay counselors to deliver psychiatric interventions. And the kind of previous slide was actually an RCT that showed when you train and supervise lay counselors to deliver psychological interventions, even manualized psychotherapy, they actually do so in an evidence-based and high-quality way. And so that's usually a model that's used in global mental health, like in settings like India and Africa where there's low resources. We decided to take that global mental health model of training lay counselors and apply it to the context of Fairhaven. And so on the left here, I won't go through all of these, but on the left here, you see sort of the traditional lay counselor as it's defined in the literature. And on the right, we show here how we kind of translated that to the Haven lay counselor. And one important difference here that I want to just underline is generally in the traditional lay counselor model in global mental health, it's members of the community that are trained. In this case, we were actually training health professional students. And in some sense, health professional students were lay because they didn't have any formalized training prior to this program in delivering psychological interventions. So in terms of integrating this new lay counselor program within the clinic, the way sort of it started was every patient who comes in for a medical visit is screened with a PHQ-2. The PHQ-2 essentially asks two questions. One, are you depressed? And two, do you have anhedonia, or little interest or pleasure in doing things over the past 2 weeks? And then patients who answered one of those questions positively, right, as a yes to one of those questions, then got the PHQ-9, which is another screening tool. And the 9 stands essentially for the 9 symptoms that comprise depression, or CIGI-CAPS as it's defined in the DSM. So this is just the PHQ-9 as it's written, and it's a very easy to follow scale. So I'm going to turn it over now to Michelle, who's going to talk a little bit more about the nuts and bolts of the behavioral health program.
Oh, thanks, Marco. So what I'm going to take you through now is some of the rationale behind the program and what we intended to have as the guiding principles when we put this program together. So as you can see here, there were 5 main principles that guided our organization of the program. The first, and these are, before I get into them, I think something important to mention is that we've tried to stay loyal to these principles throughout the program and since starting in 2012. And to really think about, for example, interdisciplinary collaboration and having representation among the student volunteers that do not only include the disciplines of medicine, but it's really an opportunity to bring together nursing, public health students, psychology. We've had someone from anthropology in the past year to really have the opportunity to work in the community, to engage with community members in offering a service that is otherwise unavailable in many cases. So collaboration is very significant in guiding the program, as well as the mental health promotion. So when we think about this, the idea is for many of our patients here in the community, they're presenting with more acute symptoms when there's a crisis, if there's a need, regardless of insurance status, we're able to find them a service system, or even if it's temporary. However, for those patients who don't need who perhaps need more of a preventative approach, it's much more difficult. And so thinking about Haven and the patients that we were seeing, we wanted to create a structure that did not require someone to be in acute distress in order to receive services. Marco mentioned the application of global mental health principles to this program, and something important to this has been the relevance, making sure that the program that we create or that the content that is provided feels relevant, feels consistent, and representative of the needs of the community. So that's something that we continue to try to identify priorities, making sure that culturally the content that we're providing makes sense and that people feel like can relate to. Sustainability and ongoing monitoring and evaluation has to do with really creating a program that would outlast beyond the funding period. So we tried in cases prior to this program to create group sessions and found that it was challenging because of the turnover among volunteers. So creating something that was sustainable and ongoing, making sure that what we were providing was actually being effective. So in terms of planning the intervention, you'll see here we have 5 questions. Marco addressed 1 and 2, so I won't go into as much detail with those. But really, these were the guiding questions in planning our intervention. What was the need, which, as Marco described, we had a population that was presenting with mild to moderate symptoms of depression. It was about 20 to 30% of the patient population. There were few referral options. And at Haven itself, there were minimal opportunities to really connect patients to services. When we look at the characteristics of the population, as we saw, primarily Latino immigrants, that's slowly changing as the clinic has moved in. We can talk about that, some of it, how that has presented in some ways an opportunity for growth and for broadening the scope of services for the behavioral health department during the Q&A. But basically, a population that is highly stressed, that has limited support networks, and that in many cases is unfamiliar with mental health services as they're organized or designed here in the U.S. When we think about the various stressors that the population was presenting with, as you can see here, there's typically a range of migration-related stressors that we talk about and the acculturative stress that people encounter when they move into a new environment. And while many of our patients would report that they moved to the U.S. searching for opportunity, and that's a pretty consistent narrative among immigrant populations, increasingly we also saw that people were fleeing situations where really they were migrating for survival. So it was no longer just economic precipitants that led them to move here, but often issues related to crime and violence and trauma histories. And that has been one of the challenges that we are facing currently, is how the demographic of patients is changing and trying to make sure that our services as well as our volunteers feel confident and prepared to meet the needs of the community. So what were our available resources? And this is where, as you can see here, but for the picture that you're seeing, that's Juan in his early days as a facilitator here in the program. And what we had when we looked at, really did an assessment of our available resources, is we were fortunate to have an enthusiastic and energetic group of health professional students who were eager to get involved in the clinic and support the community, but as was noted earlier, with a limited amount of training in mental health. So borrowing from the lay counseling approach, having an opportunity to really apply some of those principles to inform, to support, and to provide the training necessary so that students could take on the role of providing or delivering this intervention. This mental health promotion, we can say psychoeducational intervention to members of the community in a setting that was already familiar, where people were already coming in and felt accessible to care. So the role of the lay counselor at Haven has been a question from day one. And as with any behavioral health program or mental health program, really thinking about what the role is, which in this case, Haven Free Clinic volunteers are students in obviously a student-run clinic setting. Their lay counselors for the program really serve a critical educator role and are also advocates. Haven has a range of services, and as advocates, students at Haven can help connect or link patients to the necessary social supports, as well as different community resources that may be necessary. However, what the lay counselors at Haven are not are therapists, counselors, clinicians, and friends to the patients. And this has been an important distinction because many of our patients are disclosing information for the very first time when they're meeting with some of the facilitators. And it's an opportunity for them to discuss their distress, to discuss the difficult circumstances that they may be experiencing. And as you can imagine, that it's been important to offer a structured curriculum and content to avoid any challenges as facilitators provide these services. So in addition to the workforce, you can say the volunteers that we also had existing models about what had already been used by lay counselors working with immigrant communities. So here what you have are a few of the resources that we adapted when we created the program. So as Marco mentioned, the PHQ-9 is our assessment measure. And then we also looked at different resources specific to the treatment of depression in primary care settings, as well as the Tales of Coming and Going, which was or is to the right, as you can see. It's a manual that was developed in California for lay counselors working with immigrant communities. Salud para Todos, which also has some very specific psychoeducational material in English and Spanish, which we use for some of our sessions. And then the University of Washington, which has a great website with various resources regarding the implementation or integration of mental health services within a primary care setting. So our goals, as you can see here, and as many goals often are, we sort of had an expectation of how things would go in the program and then the reality. And this is not unlike, for many of our patients, also their experience of what it would be like coming to this country, what it might have been to seek services. And so being mindful, I think, of the reality that things did get complicated. They do, and we can expect that, and maintaining flexibility has been really important as we consider the program goals and as we adapt to the changing needs of the community. So we have three main goals, as Marco highlighted, the first being the provision of psychoeducational material. And what we do is through specific topics, teach patients about how their mental health symptoms, and particularly their symptoms of mild to moderate depression, make sense within the context of immigration, make sense within the context of some pretty significant losses that they've experienced. We also look at psychosocial stressors and reduction, in particular of psychosocial stressors, so trying to connect again or link patients to not only the behavioral health department resources, but also other resources in the community. And finally, behavioral activation, which is evidence-based practice and with cognitive behavioral therapy or principles guiding it, and really thinking about how do we support patients who may have stopped engaging in activities that they enjoyed or that they found pleasurable because of their changes in mood, and teaching them about that connection, as well as really encouraging them to begin to reactivate or re-engage in those activities that both were interesting to them but also brought them pleasure and can help improve their mood. So I'll now transfer you over back to Juan, who will take you through some of the specifics of what the lay counseling sessions actually look like.
All right. So for the late counseling sessions, I think one of the things that is very important is that this is late counseling, so you still need a structure, right? Like this is not a free association therapy or anything like that, but a structure doesn't need rigidity, right? In other words, patients are going to come with a certain idea of what they want to talk about, and the facilitator will have to kind of coordinate how to balance that with the goals of the session. So as Michelle mentioned, the behavioral health program is based on three things: psychoeducation, reduction of psychosocial stressors, and behavioral activation. Now, how that looks into more specifics is basically the curriculum is 6 to 8 sessions, about an hour each session, where the goals are to educate the patient concerning certain topics that have been shown to affect, so to speak, their mood, their mental health. That includes immigration, family organization, domestic violence, addiction, and just general topics concerning mental health. As far as reduction of psychosocial stressors, the specifics of it includes basically collaboration with other departments at Haven to help patients when it comes to medical literacy, economic hardships, occupational problems. We work closely with other departments at Haven to be able to basically connect the patient to the resources that Fairhaven community has. Finally, for behavioral activation, as Michelle mentioned, it's a principle of CBT, and what we're trying to do is just reactivate the patient's social networks, previous interests, and get them involved with the community. As far as how a session looks on itself, so this is basically how it is. There's an introduction, a review of previous material from the other session, going over the actual goals of the session, introducing the material of the current session, putting up an exercise the patient has to do at home, and a question and answer to see what the patient is doing. Now, even though it looks very structured here, it's not like a class that the facilitator is giving a patient for an hour. This is very interactive as the session goes. These are the 8 sessions we have, so we cover, again, topics from related to stress, mental health, family relationships, interpersonal violence, substance use. Wanted to just notice a couple of things on the slide. Up to the right, we have one of the images from basically like a little book that we use, and basically this is like to like conceptualize like the analogies we use to the patient, right? So this one is like the pressure cooker, you know, and it's related to stress, and we're trying to teach patients how with the pressure cooker, if you don't release the steam, eventually the pressure cooker is going to blow up, right? And we use that analogy to explain to patients how stress works with people and why it's important to talk to someone else. We also show patients and try to understand that mental health is not a black or white kind of picture. Like there's gray areas to it, and that the fact that they're with that, they're probably likely at the lighter scale of the gray area, and that what we're trying to do is actually, by talking to us and giving them the right services, we're trying to actually move them down to the white side, and that sometimes not addressing these issues early on is going to lead you towards the black side, which is more of like the crisis or how people think about mental health. So basically, I'm just going to cover briefly how we train the facilitators. So we train them in a few things. You know, we of course train them on like on how the program works in itself, on how to handle the first session, but we also train them on how to handle like trick situations when it comes to mental health. You know, suicidality, domestic violence, substance use. The training is done by a psychiatrist and a psychologist who have experience working actually with this population, with the Spanish-speaking population here in the New Haven area. The same folks who train the facilitators are the ones who supervise this session. So only the first session is supervised by one of the professionals, right? So the first session is comprised of the patient, the facilitator, and either the psychiatrist or the psychologist. From session 2 through 8 is going to be the facilitator and the patient themselves. You know, again, this is just like a summary of how we do it right now. This is like a current slide. Again, the psychoeducation part, the referrals, you know, which is how we reduce psychosocial stressors. And these are some of the screens we use, you know. A couple of screens we haven't mentioned before is the safety, which is a suicide risk assessment, and then the substance use screening, which is the ASSIST, another screening designed by the World Health Organization. So, you know, these are some of the challenges, you know, we're having right now at the moment. And one of them, as Michelle was mentioning, is basically changing in demographics. As of, I believe 2 years ago, the HAVEN Free Clinic, which was located in Fairhaven and mainly Spanish-speaking population, was moved to the Yale University medical campus, which is about 1.5 miles away. You know, certainly far away, not far enough that patients cannot get there. But now we have like a different patient population, you know, some different patients in the area who at times, you know, Spanish is not their first language, like the was for these previous patients, and who might have like different issues and at certain times different presentations. And again, I'm just going to briefly talk about some of the results that we actually published in the paper that we sent to a student HAVEN Free Clinic journal. So this result, as I mentioned here in the slide, is from 2012 to 2015. So, you know, at this point we have seen much, you know, many more patients, but these are the results we had in the kind of like 4-year pilot, if you know, think about it that way. So overall, from August of 2012 through December of 2015, and there's a little type on the slide, HAVEN had 390 unique patients. Out of those 390 patients, 349 were screened for depression using the PHQ-2. And out of those 349, 115 had a positive screen. 92 of them underwent the more complex depression screening, which is a PHQ-9. Out of those 92, 25 enrolled on the behavioral health program, and you know, as you can see in the slide, 67 didn't enroll, and there are different reasons why they didn't enroll. And we can go into more detail if you guys have questions later on. And out of those 25, the 18 who completed the program are here. Basically, let's see, 68% of them were female, young population, 39 years old. And you know, I think this is like the main slide in terms of results, which is folks on average started with a PHQ-9 score of 11.7. So on the first session, before you want to start basically the session, you do a screening, and this is the average that we had. And by the end, these 18 folks that completed the program, you know, on average had a score of 4.6. You know, so again, we're showing the we're kind of like replicating the same results that we're seeing in the late counselor paper that Mark had introduced about 20 minutes ago or so. Again, briefly, we have done like this survey to facilitators to assess, how much, they agree in certain topics we're trying to like teach them with the program. And the overall experience for most of the facilitators was, you can see on the top that it kind of like taught them how to empathize with this patient population, that, that these are medical students or sometimes just health professional students in general who didn't really have any much patient experience. So it's like a very important experience for them in terms of strengthening their communication skills. Also to like, I said, it ended up happening to Mark and me, to like perhaps inspire them to like pursue an actual career in the field. And in the bottom, you can see a few quotes from some of our patients. Let's see. We have already talked about the ongoing challenges, and yeah, this is basically what we have. So at this point, we're willing to take any questions.
Thank you so much for that really, really interesting talk. You guys were the first study that described a lay counselor program for treating depression in the United States, which is amazing. And I hope that a lot of other student-run clinics can, use this as inspiration to start their own mental health programs. I know that's one of my goals for our clinic here at my medical school in Texas is to beef up our mental health program, so I'm really inspired by this. One of the things that I am very interested in, I just want to remind everyone, please, if you go down the bottom of your screen, there's a little chat button. It'll open a chat, and you can send me, Amber Dunbar. You can change the name of who you're sending it to. You can send me any questions that you have that you would like me to ask the presenters. But I'm going to go start off with this first question of, I'm really interested in sort of like the kind of overcoming the barriers to setting up a clinic, and one of those main barriers that I'm thinking of that I don't really know much about, and hopefully you can shed some light. Marco kind of mentioned briefly about it, is some of like the legal or policy restrictions that come along with providing mental health in a student-run free clinic.
Yeah, that was a huge barrier for us. And as I said, originally we were focusing mostly on SSRIs for depression, which we had provided all these sort of evidence-based algorithms that primary care physicians who aren't psychiatrists can use to prescribe SSRIs. And even with all that, the sort of clinic leadership at the time that felt that there were sort of liability issues with prescribing SSRIs. And they wanted there to be in-house psychiatrists if we were going to do that. But, of course, that's the problem in this community. There aren't enough in-house psychiatrists to do that. So we sort of, went this different direction and focused on this lay counselor model. And I think the strongest argument that you can sort of make to administrators is actually just the evidence base for it. So actually bringing up the research, citing the papers that are published in high-impact journals like Lancet, and looking at guidelines from evidence-based organizations like the WHO and others that show that you can use this lay counselor model in a highly effective and very safe way. And to just bring up, one thing that I think is often brought up in the context of introducing mental health in clinics is sort of the risk of suicidality. And I think that's something that comes up a lot is an administrator might ask, well, what happens if a patient's suicidal and you have a student who doesn't know how to handle that? And so then showing them that there are actually toolkits that you can use, but to screen for suicidality at each visit, and that you have a plan should you need to, escalate a patient from sort of a clinic visit to a higher level of care in a case that they're suicidal. And I think it's also important to remember suicidality comes up in all sorts of settings, even ones that aren't like explicitly mental health care. And for example, today I was working in a neurology clinic, and a patient was acutely suicidal, and we walked them over to the psychiatric ED. And so reminding them that this is not actually a part of specialized mental health care. This is just part of being a health practitioner generally. These skills about how to assess someone for suicidality and then referring them to a higher level of services if they need it is something, honestly, that every health practitioner should be able to do, especially in a primary care clinic. And so in a lot of ways, I think thinking about it that way, that you're not providing just a sort of specialized mental health care service, but you're actually educating the entire clinic on how to be better and more well-rounded primary care practitioners is another way you can kind of demonstrate the value of integrating mental health into a primary care setting.
Awesome. Thank you for that really thorough answer. That's very helpful for me. I have a couple of questions coming in. The first question for you is for a clinic without bilingual providers, which I think is very common. I know it is common in the clinic I'm at. What advice or suggestions do you have regarding the use of interpreters?
So we've been fortunate that, you know, for the program we've had enough bilingual providers, but I think it is actually a question that's come up now for the clinic, because as the demographic has changed, we're seeing patients that speak many different languages beyond English and Spanish, and we actually have had to do some PHQ-9s doing the phone interpreter service. I think the truth is that it's not ideal, and being able to communicate with a patient, of course, in their preferred language is what we all aim for. Doing the program itself, it's not something we've tried yet through an interpreter. It is a question that has come up. We think because the material, and Marco spoke some about this just now, but in terms of it's not a treatment program, it's a psychoeducational program, so the material that we're providing can be delivered in a pretty structured manner. I think that there would be the possibility, would be my impression, to provide it. I think one of the drawbacks is, of course, that you lose potentially some of that rapport that is important to creating a comfortable environment for patients. However, I think the question is the delivery of the content through an interpreter. It's something that can be done.
Great, thank you. Another question that the audience has is, what kind of follow-up, or is there follow-up with participants after the sessions are completed, and any assessment of what the participants are still using as far as the tools that they learned in the program after they've finished?
So we don't do any formal follow-up with patients after they complete. However, anecdotally, we've had several patients who have reached out that they've wanted to continue with the program or come back to the program. So at Haven, many of the patients, or all the patients that we see are currently registered as patients who are receiving some kind of other service at Haven. So for the most part, patients remain in clinic even when they're finished with the behavioral health department. And so they not only continue to be screened potentially with the PHQ-9 in future visits, but also remain connected to the clinic. So we have had some patients that when we revised the curriculum, chose to re-engage. And so when we didn't mention this, but when the curriculum a couple of years ago, we decided to revise it, mainly on the idea of having more skills-based modules and offering something more practical for each patient at the end of each session. So we've had some patients participate in that piece, but we don't do a formal follow-up with each person.
Okay, thank you. Going back to you just reminded me, going back to the changing population that you're experiencing now that you moved clinic sites, and I think that so it's a new patient population, and a bunch of the other student-run clinics around the country have different patient populations. I think some of the large ones are homeless populations. What advice do you have? I guess the things that you're learning right now as you're trying to do it, what advice do you have for other clinics in trying to adapt this specifically to a different patient population? Or is it too early to tell?
Yeah, so I'll just say that, like, as you can see, like, our curriculum was, like, heavily focused on the fact that, like, a lot of our patients are immigrants. But as we started the curriculum, we learned more about the actual current needs of our patients, right? And we realized, like, yes, immigration has been a big stress for them, but they're struggling with like things like you and I, who perhaps didn't immigrate in the same circumstances, are struggling with, right? They're having issues with their relationship, they're having issues with their current boss, etc. So I think what the point that I'm trying to make is that you can start with like a more of like a generalized template of a program like this, psychoeducation program, and then you can actually like learn more of your population as like you have sessions with the patients and tweak it as time goes by. Again, every population has different needs and also different resources, right? You know, if you're homeless and you're a U.S. citizen, automatically you can access like a lot of resources. Some of our patients who are undocumented cannot access, right? So it's all about like kind of like, for lack of a better word, studying the patient population you're serving.
Mm-hmm. And in response to some of that, as we begin to see this demographic change, we actually recently created and started piloting a wellness curriculum, which is for patients who are primarily English-speaking. So that was an interesting, I think, just the anecdote in terms of the program of really adapting something that is in Spanish to English. And what it is a 5-session program that focuses on general wellness principles. So from SAMHSA, which describes the 8 dimensions of wellness, really trying to assess for patients how do they feel that they fit into those areas. So, for example, how are they on their not just social and emotional health, but physical health, spirituality, issues of employment. So all the different dimensions that we think can make up wellness, and provide sessions on stress and general mental health education specific to depression and anxiety. And we have a session on problem solving. So it's a little bit shorter than the Spanish curriculum, but we try to provide some general guidelines and wellness principles through that.
And just one more piece of that is I think it's important to remember with this particular program that we were actually taking models that were primarily tested in Africa and India, which are obviously very different settings, this sort of lay counselor model, and applying it to a new site. And so I think that's what's generalizable is that you could sort of, especially in a student-run free clinic setting, is that you can empower students to deliver sort of psychoeducation services and first-line interventions for depression. And this is sort of a structure that you can use to do that. And what that psychoeducation is actually going to look like, exactly like Michelle and Juan have been saying, is going to vary depending upon the exact population you're working with. But this sort of provides a structure that can sort of travel to different sites to actually empower health professional students to provide this kind of care.
Great, thank you. Another question from the audience that we have, Marco, you mentioned that you received a Helping Hands grant. The audience wants to know, what did the money from the grant go towards, and what financial costs are there to maintain this program?
So the money from the grant, and I think it's important to think about grants in somewhat of a critical way, because grants are sort of one-time payments. And so if you're using a grant to sort of say this is going to fund the program, indefinitely, that's obviously not going to be the case, because there's sort of these one-time payments. So you need to think, I think, strategically about like what are the sorts of things in your program that you sort of need one bolus of funding to acquire, and then from then you can work on sustainably without that money, because you're not going to have it from year to year necessarily. And so for us, we essentially set up the program, and then sort of the structure of it, we figured out who was going to train people, how it was going to be set up. But then we realized we needed sort of just very practical like resources, like notebooks, binders. We wanted to buy this Tales of Coming and Going manual that was created in California, and we realized that might be really good. We wanted to buy that, as well as this. They have this beautiful, I'd highly recommend it if anyone else is working with the Latino population. It's a beautiful curriculum, and they have this sort of placard board with these large images, like the pressure cooker that we saw as an example of it. But they sort of go along with the lessons, but they're rather expensive because they look very nice. And so essentially we identified these sort of very practical materials that we would need to to kind of keep the program going. And again, these were resources that we could kind of use from year to year, right? Like we could buy them one year and we wouldn't need to buy them the next year because we would have them and could sort of bring them on. And then the other thing, we also had some money for the actual patients, and we provided bus passes to some patients who couldn't make it to the clinic otherwise. And we used some of the funding for just to allow people. And then I'm going to let Juan talk also about a second Helping Hands grant that we got.
Yeah, so actually for the program, we ended up getting a second grant. I'll say 3 or 4 years after Marco got his. So I think it's around 2015, and we used that grant, to address some of the shortcomings of the initial curriculum, which was the substance use screening area. And for instance, for that part of the grant, what we did with the money was again, just fund a lot of the material resources that we needed to screen patients. And also, we realized we also need some more money for bus pass. We needed more money, so we just allow ourselves to have more budget for that part. And we actually did end up using the whole budget for the grant that time.
And I'll just mention briefly, so Helping Hands has been a strong supporter of this program, and we've had opportunities to continue to broaden the scope with that support. So in this past year, Abby Green, who is an MD PhD student and former behavioral health director, was applied and was successful in obtaining a grant from Helping Hands to create a community education workshop series. So what it was an opportunity to have parallel set of workshops, 3 sessions each, and thinking about the integration of mental health services and primary care. So we had one series of workshops that were designed for health professional students, where they learned about how to think about mental health in a primary care setting, how to think about asking those questions around trauma, specific to both immigrant and refugee communities, since here in New Haven we also have a large refugee community. And then a parallel set of workshops in the community at Junta, which is a local Latino immigrant advocacy organization, and also IRIS, which is one of the refugee resettlement agencies here in Connecticut, and had sessions at those sites with community members about how to bring up mental health concerns in a primary care visit. So we had 2 sessions and then a third session that brought health professional students and community members together to think about what are the expectations that each group brings to a visit and how to think about more effectively communicating. So we've been able to do that through the Helping Hands support.
Great. That's really awesome that you're able to get all that support from them. Another question that we have is, so you guys had 6 to 8 sessions that the patients had to come back to. How did you promote patient retention in the program?
Yeah, so I think it's actually a very good question, because throughout the years, one of the struggles is that patients start the program and then they drop out, right? If there's a slide where I show you guys that, I don't know, in theory, 95 folks were eligible for the program, and we offered the program to all of them, and some of them started it, and not all of them ended up enrolling. And I think it's 25 enroll, and really only 18 completed the program. So I think, again, a key thing is to understand your patient population, right? So is to understand some of the barriers some of the patients we're struggling with, If transportation was a barrier, which we tried to identify it on the first session, and we'll, give the patient bus pass if that was the case, But another thing is just in general, this fear people have when it comes to mental health, and also time commitment, So we try to work with patients, there's a lot of patients who couldn't do 8 sessions in a row, right? In other words, session after session after session, week after week. So they ended up taking maybe 3 months instead of the 2 months, right? And taking time in between sessions, So it's just really working with the patient. Another thing that's important just to say, and that happens, since I'm in psychiatry now, it's just the rapport the facilitator has with the patient. So when we're training the facilitators, we're just trying to emphasize how much, the first session is really them trying to connect with the patient and hear what the patient kind of had to say and what they kind of wanted out of the program. instead of like kind of like giving the impression that like it was just going to be like a class or something like an hour session where the facilitator is going to be talking to the patient wasn't heard, So again, just summarize, understand your patient population, understand the needs that they have, and be able to rapport with them in the first session.
Great. Another question that the audience has, how do you promote interprofessional collaboration with the social services department when you're addressing those stressors that the patients come in with?
Yeah, I think that's a huge part of it. And I think that that was often, I think, the draw for a lot of patients is that a part of our program was not just kind of, working with them psychologically and emotionally through the psychoeducation, but we also wanted to figure out what are the things that are leading in your life right now to a depressed mood, and how can we potentially help with those. And so what we would do sort of in the actual initial meetings is kind of do an assessment with the social services department of are there areas of need in the patient's life. And this is everything from access to food, to access to housing, to employment issues. So all of those things were kind of screened for. And then as the patient was going through the program, we would have a social service, someone from the social services department who was working with the patient to address those issues. And so that's how we really and actually just the way the program developed, it didn't necessarily have to develop this way, but I was actually director of the social services department myself when I started the program. And I think part of my seeing how much need there was for mental health services in the department is reflective of the fact is that people's sort of psychosocial stressors are so tied that we would see in the sort of social services department are really tied to their emotional well-being as people. And so it's been a really close relationship, I think, from the start and continues to be.
Awesome, thanks. And we'll do one last question that we have. So it says, I noticed that about 350 patients out of the 390 total patients that were coming to clinic were screened with the PHQ-2. What methods did your clinic use to get such a high screening rate?
Yeah, it's a good question because the reality is it's not just it wasn't us, it's in the facilitators in the program doing the PHQ-2 screening. It was actually the medical team, right? So since we started the program, when we piloted the program, one of our big emphasis was to integrate the PHQ-2 screening into the medical visit, right? So a way in which we did it is we, like most clinics have, we have a template that the health professional student who is actually doing the medical visit has to fill out as part of the workflow of the visit. And in that workflow, we included the PHQ-2, right? So for a person to say that they thoroughly screened someone, for medical issues, they will also have to include the PHQ-2. Having said that, initially, and I'm probably just too naive, initially I thought when you were going to have it in a template, our success rate was going to be 100%, right? But, at the end of the day, folks want to ask what they want to ask, and what they think, what they prioritize is important, But, as the person who asked the question, 340-something out of 390, it's a lot, and I think it's just the emphasis we gave to the clinic as a whole that mental health was important and that they were basically the bridge to our services, right? And if they never ask the questions to the patients, then these patients will never access the services we had, So we just, for lack of a better word, we make it a requirement for them to ask these questions by putting it on the note.
Thanks. Are there any last thoughts that you all have that came up while we were asking these questions?
I'll just say this, I think I hope that our talk inspires a lot of clinics to look into what barriers they have as far as lack of access to mental health services, to study their own patient population, and at the end of the day, to use the resources that you have as a student, right? The Helping Hands grant is out there for anyone to apply for it, right? And I don't think they get that many applications. I think they actually fund most of the applications, and if you look at the requirements, it's really just that you're a medical student who works with a underserved patient population, which is basically like the patient population of every free clinic, you know. So, you know, it's out there for the grab, so to speak, you know. And I'll just say this, you know, like sometimes $5,000 is a lot of money, but if in the greater scheme of things, it's not that much money, right? But the fact that you're actually getting a grant for a program, right, gives a legitimacy to the program, right, and actually makes people want to keep the program going later on, right, instead of like just being like a very basic idea that someone had 1 year and then it just kind of went away. You know, when you actually have like funding behind it, you know, and you actually have like a big organization who donates into it, folks are more likely to like keep the program going.
Yeah, I guess I would just second Juan's statement in just the basic point that it's possible to deliver high-quality mental health care in student-run free clinics. And if you feel inspired to do so, there are resources from the Helping Hands Grant to psychoeducation models to other people around the country who are doing this. From, you know, us with our program, we looked actually, Mount Sinai in their student-run free clinic has published some great papers on the treatment of depression in student-run free clinics using PHQ-2 and PHQ-9. That was helpful. It's just the basic idea that there's a community of people doing this, and I think as maybe a lot of the audience has felt this, if you've tried to integrate mental health services into a student-run free clinic, there will be a lot of people who may tell you that that's not possible or it's too risky or all these sorts of things. I hope this serves as some convincing evidence that it is possible, and there are people out there who are kind of willing to help you realize those goals and resources out there to help you do it.
Yeah, and I think it's really emphasizing that piece of the resources that we do have, and that if we broaden our scope to think about mental health services and treatments, to go beyond some of our traditional models and really think about prevention and psychoeducation, and in the student-run free clinics, the resources that we have with the students who are interested in doing this work, that our workforce really is a lot bigger than we may sort of be limiting ourselves and thinking if we're just thinking about specialty care. So that there are opportunities out there, as we already mentioned, with the funding sources, and that in addition to being opportunities to train in mental health education and prevention models, that it's also an opportunity to learn about advocacy and the importance of social justice as a theme in this type of work, and that there's opportunities to really wear many hats and to really come to the crossroads, I think, of what professional practice is when we're working with this community. So.
Great. Well, I want to thank you again so much for this wonderful, wonderful talk. It's really helped me a lot in trying to get the sort of a vision of what I want to do with our clinic here, and I hope that that's been the same for other people. And we would give you a big round of applause right now if we didn't have everyone on forced mute, but we really appreciate that. Before ending, I just want to thank the participants as well for joining us for our very first webinar. We hope you've enjoyed it. I'm going to be sending out a survey to receive feedback on this seminar as well, and we hope that you'll provide us with some good information so that we can improve and kind of keep these webinars going in the future.
Great.
And
just,
go ahead.
Really quickly, we just wanted to thank you for inviting us to this webinar. It's also been a wonderful experience to us and to get these excellent questions. And we also hope this can be sort of a platform for potential collaboration. So, you know, if people have questions and things, please reach out to us. I think that's what I find to be valuable about a lot of these sorts of talks, is that you can kind of build connections with people. So thanks so much, Amber. Really appreciate it.
Oh, thank you. And if anybody is interested in getting more involved with our Journal of Student-Run Clinics, we always need reviewers. We always welcome articles submitted. So please reach out, and I can let you know how to get more involved. All right, and so that's it for tonight. Thank you very much. Have a good night.
Thank you.
Bye. Thank you.